Ms. Moore.
Thank you. Good reminder to get the car in this weekend. I appreciate that. Dr. Miller, there have been concerns that you actually just all of you answered lots of questions, a lot of questions that they got to answer. I'm going to ask just two individual ones. Love some context on it, but it's in relation to what we just heard. Concerns about upcoding, right? So let's dig into that a little bit. Concerns that upcoding in-home risk assessments is increasing the cost of Medicare Advantage. So a specific example for the taxpayer. So the cost is going up. Medicare Advantage insurers appear to be using health risk assessments and chart reviews to inflate payments for Medicare. In 2023, insurers received billions in payments for diagnosing patients during home visits with new conditions and that apparently don't warrant treatment. Several health plans have been sued for under scrutiny or either failing to remove inaccurate codes or willfully upcharging. We have to get a handle on these out-of-control costs. I think we've established that today. How can lawmakers best ensure that Medicare Advantage accountability without sacrificing services like in-home assessments? Because my example here on in-home assessments isn't saying that they're not worthwhile. I'm just saying there's been some taken advantage of here. How can we balance the accountability without sacrificing these assessments?
So you want all patients to be completely and accurately coded for their diagnosis. If they have diabetes, you want to know whether it's controlled or uncontrolled. If they have kidney complications, nerve complications, visual complications, you want that all coded appropriately. What you don't necessarily want to do is incentivize plans to just go harvest diagnosis codes to get paid more and not do anything about it. So the way to do that is to integrate diagnosis coding into routine clinical practice, and we could do that by having it be a component of electronic health records. So instead of me as the physician selecting that the patient I've admitted to the hospital has X or Y or Z diagnosis or some coder going after me to tell me to do that, have the software automatically code that, because and then have the physician make a decision as to whether it's appropriate or not at the point of care, and then that gets onto claims for fee-for-service and Medicare Advantage beneficiaries.
And I don't know all the specifics of this, but as I've been involved in these issues, I've seen a lot of discussion about you can use pre-existing data to get some norms and generally target what's needed and get pretty close. And then I like the part that you just mentioned, that you would have the physician be able to make a final determination on what's really necessary.
Yeah, and make it just, again, you can use doctors, nurse practitioners to do documentation. That's probably not a great use of our brains and time. Like, we can do that, but that's not what you want us to do. So making that just a routine automated process, just like spell check, autocorrect, completion of emails from your Apple iPhone, making diagnosis coding that way and having that engine pull from labs, imaging, notes, that would just make it easier, and then you'd know that the patient is completely and accurately coded, whether it's in fee-for-service or Medicare Advantage, or whether they're on Medicaid, or whether they have commercial insurance, and then you would be facilitating better clinical communication because the chart would have the diagnoses that the patient has.
Yeah, love it. Thank you very much. Mr. Jane, the Medicare Advantage quality bonus programs may have started as an incentive for better care, but without being regularly updated or tuned up, as we've now established, it has become less effective. The star rating system, for example, is complicated. It considers a lot of different measures. The ratings are reported on a contract level rather than a plan level, which ropes in several vastly different benefits, networks, populations, making it hard for an individual to make sense of the ratings. How could a more efficient value-based system that focuses on outcomes and quality metrics provide more transparency and easily digestible information for seniors in particular?
Yeah, I think there's not enough attention paid to star ratings at the point of sale, and I think there's two reasons for that. One is I think there's not a lot of belief in the star ratings by brokers. They're not necessarily convinced that a 4.5-star plan is better than a 4-star plan. And to be fair, there's one of the challenges with the system is that very small differences can lead to big swings in performance in the star rating system. So in that way, it's not really as robust as it should be. Am I confident that a 4.5-star plan is better than a 3-star plan? I am. But am I confident that a 4.5-star plan is meaningfully better than a 4-star plan? I'm not. And so I think that the reality is that we need to actually be, to revise the system so that differences in star ratings actually mean something. And I think that right now, consumers don't necessarily feel that, and they're not being told that by brokers who don't necessarily have that confidence either.
Probably a great time to finish that I just checked in my Uber profile as a passenger is 4.84, and I just wanted that to be on the
Mr.
record.
Moore, you're better than me.
I wanted that to be on the record, and I yield back, Chairman.
So now we know Mr. Moore is a big tipper. Mr. Horsford.